Good morning, Jill. We're just going to give it another 2 or 3 minutes. People are still gathering here. Thanks. Good morning to those on the phone. I'm going to give it another 2 minutes from here. I'm hearing people join. Thanks. Good morning. Welcome, everybody. Yes. Welcome to those in the room. Welcome to those on the phone. This is our cost quadrant meeting for this month for APCM. let's go ahead and take a look at our agenda, and then we'll do introductions after that. I'll begin setting the context and reminding us all of why we're here today, and then I'll hand it off to Laura, who will review the first version of that report just briefly again, and then discuss other reports that we could potentially align this one with, and also share some of the information we got in follow-up from OHA. And then the bulk of the meeting will be a discussion with all of you about what we want the reports from OHA to include. And we will wrap up as usual by talking about next steps. Since we have so many in the room, maybe instead of doing it by phase, we can just sort of do a round robin here and then do the phone if that works for everybody. Let's start, so I guess name, organization, and title. Want to start, Brandon?
I'm Brandon Lane. I'm a data analyst here at OPCA.
And I'm Amy Bassarino, APCM manager, OPCA.
Hi, this is Summer Brazell, office coordinator at OPCA. Erin Kurtz, quality manager, OHS Richmond.
Hi, I'm Ron Chow. I'm the CEO of the Community Health Centers in Lane County.
Debbie Powers, Multnomah County, Clinical Operations.
Tasha State, Multnomah County, Primary Care Services Director.
Good morning, Tim Hines. I'm the CEO at Valley Family Health.
You're right in time.
Hi, I'm Kristen Trotter from the Valley Pharmacy Clinic.
Laura Tisolak, Network Development Director, OPCA.
Hi, Joan Watson-Patco, Executive Director, OPCA.
Hi, I'm Karen Hudson, data specialist.
Thanks, everyone. Let's go ahead and turn to the phone. Who do we have on the line today?
This is Renee Taylor from Waterfall.
I heard Renee. Welcome.
This is Carla Jones with the Community Health Centers of Benton and Lynn counties.
Great, thanks, Carla. I should also add that Renee is with Waterfall.
Sorry.
That's okay.
Jill Borovansky with La Clinica. I'm the CFO.
Good morning, Jill.
Tracy Neal, Director of Analytics, La Clinica.
This is William North with Rogue Community Health.
Gil Munoz, Virginia Garcia.
Welcome, William. Welcome, Gil. Can everyone on the phone see the screen okay?
Yes.
Perfect. Did I miss anybody before we move on? Okay. Okay. So just a quick reminder about how we arrived here today. Jamal, before he left OHA, did a lot of work in this domain. He's the one that sort of kicked this off with the health analytics team at OHA and developed that first version of the APCM cost dashboard. We were able to share that sort of static, blinded version of that dashboard in November of 2018 with all of you. And then the following March, so this past March 2019, we looked at that blinded dashboard again, but in more depth, and made some decisions that same month at the APCM Leadership Committee meeting, which I have on the next slide. These were voted upon by all of you and approved, so we decided that this work group, the cost quadrant work group, will sort of stay with the executive directors for now and their designated secondary representatives, and that's been a lot of CFOs and also a couple of data people. And then we also said that once we would start receiving the cost reports from OHA, which we're expecting maybe in early 2020, at that point, this work group will be discussing the data transparently, and that means that health centers will need to opt in or out depending on whether they are willing to share their own data. In July, we had a meeting of this work group, and we heard a lot from OHA there. There were 3 from OHA, Kathy and Kim from the health analytics team, and also Michelle Mavison, who's currently our person there for everything APCM. She's on her own for a while. We were able to ask them, all of them, quite a few questions and clarify what they had on those reports. And at the end of that meeting, we said that the next step would be to convene the health centers only without OHA, talk about what we'd want to have in that proposal eventually, which brings us to today. We are hoping to narrow what's in that desired report, so what elements are included in that report, so that we can request that from OHA, and we are going to do that by very quickly reviewing the current report once more to get us back grounded again, and then discuss other examples of cost reports that we've heard from partners, and finally discuss what information we would want to include and exclude in the OHA report. So I'm going to hand it off to Laura now.
So before I jump into these, just want to see if there are any questions or about how we got here today. Okay. When we talked with OHA in July, we also spoke a little bit about some shared goals and some things that some of these that health centers raised and that OHA raised as well. And so we talked about an interest in aligning with CCO reports, and when we start discussing other reports that we've been taking a look at or having conversations about, actually, I would say we've not yet gotten access to those. Folks had said it would be great if, to the degree possible, these looked like the same things that I'm seeing from my CCO. So that was one goal that folks sort of shared here. When we talked just broadly about the goal of getting access to these reports and what we wanted, it was really about becoming educated around total cost of care data, the drivers of those costs, to understand sort of where health centers are as a baseline, and a lot of folks speaking about this as an opportunity to really understand program impact potentially. Folks may remember from a few years ago, the state commissioned a analysis or report by Optimus to kind of look at the financial impact on total cost of care for the, particularly the pilot clinics that started out. And so I think when we started talking about access to cost reports, I know a number of you raised the possibility of having the kind of data that might be able to replicate or provide similar evidence of value of the program. I raise these because I want to see what else people might have to add, but I also want to illuminate sort of what isn't here based on what we've talked to OHA about, which is, you know, they shared in our last meeting some of the limitations that they'll have, and that this will not be real-time data, probably will be quarterly reports. They won't be, I believe they said, will not be patient-level data. So just wanting to be clear in our conversation that we aren't, we're not really talking about data that you're going to be able to get and use to manage your population or to really probably even drive like a nuanced look at quality improvement. It's more looking at benchmark, understanding those reports, and as I said, kind of considering through trends or what have you, are we able to say anything about the impact of the program? So let me pause and see if there are other comments, questions, thoughts about those goals.
I think one aspect, maybe it's implicit, but I'm wondering how we can make it more explicit. For those on your phone, this is Ron, is what do we know about how OHA is looking at this data? You know, what are their markers by which they will view whether we're successful in the APCM program, and at what level of granularity are they looking at the data? Or are they pretty much saying on an aggregate member month basis, you know, does it cost more, does it cost less for Medicaid members? Because we wouldn't go down to the individual member level, but even what's it doing by, for instance, the different rate categories, you know, the 6 or 8, however. Yeah. You know, the rate categories, because there may be some components costs that really are completely outside of the rate categories or cost drivers, Hep C drugs or something like that, that, you know, there's a change in the benefit or a significant change in a cost driver that they might otherwise attribute, well, the APCM program isn't really very successful. And to the extent that we know what they're looking at, how they're judging Medicaid overall, but particularly APCM, that would be helpful.
And this is Christy. I agree with that, Ron. I think it's important that they don't just do this high-level total Medicaid comparison, because even within different health centers, we have very different demographics as far as the type of patients we're seeing, and we don't want to be compared to someone that only has traditional Medicaid to a center that has SSI.
Right.
So,
and I don't want to get too far in the weeds, but I think we should start to lay the groundwork of some of the things that are not captured today in claims that are cost drivers. As an example, we've been working with our local CCO and a different part of, those of you may know, I'm part of Lane County, a county organization, and so outside of the community health center, our local CCO has been working with our public health and our overall data analytics group at a county level. And we've been working with the CCO not just to get our CHC cost data, but the total CCO cost data. And we've overlaid that against analysis that we as a county have for homeless status and the point-in-time count and other data that we have as a county across the overall county population, and then looked at that against the CCO's total cost. And one of the things that we found, not a real surprise, the most significant correlate between extremely high cost was housing status, or quite frankly, homeless status. Much more than SPMI or some other diagnostic conditions. And so, again, not a surprise, but folks who were homeless and severe and persistently mentally ill were, you know, I won't quote because I'll be wrong, but, you know, 8 or 9, times the cost. It was extraordinarily high cost. And then we drilled down to say, as a community health center, how many of that CCO's homeless, what percentage of that CCO's homeless population do we have? We have, the community health center, 27% of that CCO's homeless. The next biggest medical group in our community has 13%, and then it goes down to less than 5%, right? So absent knowing that homeless status, you would look at our costs and you would go, what the hell are they?
Yep.
And so, you know, I am a little concerned that as the state is looking at the community health center costs versus non-community health center costs in this sort of arrangement, that would be completely lost because it isn't captured in claims. So it maybe just, you know, kind of laying that groundwork that CCO 2.0 gives us the opportunity to start to think about those as potential, you know, cost drivers.
Yep. Great point. And I wonder if that's something, I know we're going to have some further conversation about an upcoming meeting with the Medicaid director, and I think those points about patient complexity and what have you might be relevant to share. I know we're going to talk more about that. Other folks, I'm looking in the room and want to make sure people on the phone have an opportunity to chime in on these points.
This is Gil. Laura, you referred to the Optimist report, and I think one of the helpful things about that report was that they were able to do some predicting of what the cost would be normally, and then they overlaid, and these are what the costs actually are, you know, for APM clinics. And I don't know what our ability or the state's ability to replicate that kind of analysis, you know, moving forward. But, you know, as we're trying to evaluate the success or the value of APCM, we need to have some kinds of guidelines to know if we're going in the right direction or not. And on the CCO level, there are targets that they have for, you know, member benefit ratio or medical loss ratio, and then they can track, you know, what their costs are in comparison to that target. And if they're below, they know they're doing well. If they're high, then, you know, that's a bad thing. But with APCM, we don't have a similar kind of target because we don't have a premium or, you know, something, you know, for us to be working with. So we're going to have to come up with, you know, other ways for us to evaluate that cost of the program in relation to what predictive total costs should be for similar population. And, you know, I think all the nuances to that, as Ron, you know, very ably, you know, described, you know, impact, you know, what those costs are. So, so anyway, I think, you know, part of the shared goals with OHA really is for us, in collaboration with them, to better understand what those cost drivers and have it as a learning, you know, both for OHA as well as for the health centers, to really grapple with the costs for the population.
Thanks, Gil.
I guess this is like real kind of down in the weeds, but just thinking about the Hep C stuff and the other really population specific, if there's a way to maybe carve out some of that stuff that, like, obviously a lot more of that's been happening recently. So just for the
things that are
I think
substantial.
like that, yeah, yeah, and like varied population.
Yeah. Right. Okay, anything else before we move on?
I have a quick question.
Yeah.
How are they factoring in our FXD reimbursement in determining cost? Is that part of our
So what I understood from sort of their first take was that it didn't include RAP. Is that your question? Yeah. That was my understanding from their first take at the report. So because that's not a claim-based, you know, these are essentially claims that they're pulling together. So
do they have any plans of incorporating that? And I guess I'm just thinking down the road, it's like, that does cost them money.
Yeah.
So how are they going to factor that into?
I don't think we've crossed that bridge yet. And, you know, I'll say too, I think folks, you know, Amy in our introduction mentioned, you know, Jamal was really, I think, a driver of this on their side, and I think had already started looking at and kind of playing and digging into what could they do and find and see in those cost reports. And I don't, and so he's then, he had started this process with some folks in health analytics, but I don't think that they have done as much thinking about what they want to see and why. So, So I don't want to spend a ton of time on this first report that we took a look at, because I think you all will remember it was pretty high level and not particularly useful, but I just wanted to remind you kind of where we had started. So, and what they're talking about. So again, they're talking about quarterly data. There were some things really strange in here about how there was a big jump. So there's going to be challenges with lags in this data that will affect that. So we're going to want to think through that. And then this, I don't think they were even able to clearly articulate whether these were unique patients. We talked about, I think, wanting to look more at member month and other things. But that they're, they had this cover page sort of that talked about just a broad total cost number. And then they shared kind of what, at a very high level, those buckets were. And we spent a lot of time, I would say, on the third, just asking questions about this. And in a few minutes, we'll go into the follow-up that we did with them and show you the sort of the detail that's behind each of those categories, their groupers, and just to share, how they might be able to dice this differently and provide more detail. But these are the major categories that they were able to share.
By clinic, they're referring to organization, right?
Correct. Yeah.
And Laura, so on the they're including dental costs, and so I'm assuming they're also including like mental health and OB costs too. These are currently services that are carved out of APM.
Correct. So I think when we get to it, that may be a particular point that we're going to want to pull those out specifically.
And I remember, did we have this specific question around how is specialty mental health? What bucket? Where is that?
Yep. So we'll get into that. The last thing is I think was their attempt to try to get to utilization, and I think we'll talk a little bit later about, my sense from a lot of folks is that we want to be able to get to utilization as much as cost, so that we know if a cost bucket, let's say for inpatient, is based on a few high cost users, or is it a high level of utilization at lower cost. But the way this is framed doesn't really do that. And so, and yet this was also not particularly useful. So any questions? Like I said, I don't want to dwell too much on what they started with. Yeah. Okay. So other reports. You'll remember, as we talked last time, one of the things that folks had asked us to do, I'm going to stick here for a minute, was to with the goal of aligning with other CCO reports, was to talk to some folks about CCO reports. What do they look like? And we had a couple of meetings with Care Oregon to talk about reports that they're currently working on to provide to their providers. And would they be willing to share that with us to look at aligning those to the degree possible? They're very willing, and as you might expect, Care Oregon has had a lot on their plate these last couple of months, and so they don't actually have those reports created yet. They're still working within it, but we did learn a few things about what their intention is, and we have some follow-up stuff. So number one, something to be clear about for those who work with Care Oregon, they're talking about reports that would also be I think point-in-time reports, not real-time data. They do, for those clinics that are involved in their risk model, I know there are some clinics getting through their contractor more of a data, a claims feed, and more real-time claims information. That is not what Care Oregon's talking about across the board. So they're not, when they're talking about what they'll be providing to all of their providers. It's through their Arcadia system and some analytics around cost and utilization and some of the metrics to which Care Oregon's held accountable. So, and that they're sort of stepwise trying to figure out that functionality and figure out what they want to see in that. We shared, you know, where we were with OHA, and I'll get in a little bit to the groupers, or again, the detail behind the state's reports. And the next step we identified that they were very willing to do was to kind of do a crosswalk between how they define professional services and how they break that down and what they're trying to sort of put in front of their providers around defining professional services versus what the state's categories are. And can we get to, you know, Fuji and Gala apples at least? So that would be the next step we talked about with Care Oregon. I also spoke to Marshall at Mosaic, because as we've talked over the years, I know that Pacific Source has been pretty generous with their IPA, or they've for a long while had access to some total cost reporting through their IPA and Pacific Source. And Marshall actually, Marshall, are you on the phone? I should check, because I don't know if you're here. No. So what he shared with me was that actually he said they've been a little haphazard of late in terms of how frequently we're getting those. And he articulated really that he'd be happy to share. They've actually been struggling with the utility of those reports and really getting to information that can drive decisions about, you know, that might guide some care model decisions or quality improvement or what have you. He said, I'm not trying to be negative, but he said, once you get and you wade through sort of the volume of data in some of these reports, it's hard to get to what's really useful. He did say, with that said, he's happy to share, and that there are, you know, probably one of the things that he finds of most value is sort of understanding and knowing what the CCO is looking at, and to be able to hear more directly from them what they're looking at in terms of cost drivers and what have you. So again, he didn't actually get the report to me, but is willing to. So one of the other things then we looked at were just some other out there in the ether, and I was going to pull up the sample report from Comagine to just start talking about and looking at.
So Laura, maybe I can just jump in.
Sure.
I'm happy to share the reports that we're getting
Great.
Trillium. More of the members may be working with Trillium come January.
Mm-hmm.
We're getting aggregate reports and some comparison reports of our performance compared to peers. We're also, on a monthly basis, we're also getting monthly claims downloads, which includes all of the claims paid for members attributed to us, and then some level of detail on those claims. It's not to the level of detail that I would like yet, but it does give into pretty much the Milliman and Robertson's kind of standard breakdowns in terms of expenses. So
great.
I'm happy to share that.
That'd be great. And I know Marshall, that I think the reason that we don't have it in hand yet, he wanted to black out content. Totally get it. We're just looking at what they're measuring. And so that would be great. Anyone else or other ideas from your own CCO experience? And I raised this really just to say we had hoped to come here already with that information and be suggesting, but I think we're just going to kind of go in reverse and get some of your thoughts now and then look at those samples before we try to put together something for you to react to.
This is William. I guess I could wonder if Care Oregon would be willing to have us share the Wakely data because that's what we've been getting. It's a monthly claims-based file. But they've done some analysis around risk stratification associated with that. And so we have a tool that they've built off of that allows us to really kind of look a little deeper. And I don't know if Care Oregon would be willing for us to not share obviously the data, but maybe the structure and how that's set up. I could ask them about that.
That would be great, William. As I said, we talked specifically about that with them, and they were clear that they weren't willing, they wanted to be clear that they weren't preparing to share those kinds of reports with all clinics unless they were participating in the risk model, in particular because they pay this third-party contractor to produce those reports.
Right.
With that said, I love your thought on what from it might be of value and can be brought in, and in particular around the risk stratification question. So thank you for having that conversation.
Okay, I'll do it.
Okay. So, Summer, where do I get that?
Should be here, right? Okay, yeah.
So, a word about this Comagine report. This is a sample on their website, and I want to be clear, we're not suggesting, this isn't even Medicaid data. Comagine, as you may know, is the quality contractor, I forgot the name of that, or quality QIO, formerly Qualis, formerly Health Insight, formerly a few places. It's all up there. So they're the QIO. This is, I think, for all payer, all claims, their sample for all payer, all claims. So we're not suggesting we use this report, but when I was thinking about how are we going to get some feedback about what feels good, what's important, what looks right, it's helpful, I think, to be looking at an example. So that's the only reason I raised this. I want your reaction, thoughts to what seems valuable, and I'll also caution that because it isn't based in Medicaid data, it may not, some of these things may not be feasible for OHA to produce. So that's my caveat. That said, one of the things I wanted to raise in looking at this was the risk score concept, and given some of your comments, Ron, I think one of the things I'm hearing pretty clearly from folks is that we want to be thinking about how risk is reflected in these reports, and it's, so I think we want to hear more about the state's risk adjustment model and how that might be brought into these reports. And as I would expect, to Ron's point, it will be inadequate relative to social factors and other things. So how do we consider adding to that analysis in a way that will elevate the issues of risk that we're concerned with? So, but let me just pause and see about thoughts on risk score. As I said, this is really a very specific risk adjustment methodology, the Johns Hopkins thing. So this is probably not exactly what the state uses, but.
So, Laura,
yeah.
This is Gil. I think, this is a good starting point, but is inadequate for all the reasons we've been discussing. And, one of the things that OCHIN has done recently in terms of trying to get to social determinant risk adjustment is they've overlaid the information based on census tract information on distressed areas, distressed communities, and with that they've been able to do some really interesting kinds of analysis that shows when you overlay those factors that are really attributed to high distress or social distressed areas, that it impacts things like diabetes control, and it's not as good as having, you know, by patient, you know, exactly, you know, a social determinant measure, but it is a pretty good proxy to start with. And so that might be something we consider in terms of trying to overlay or adjust the something like the Johns Hopkins methodology.
Okay. So generally speaking, I mean, you speak to census tract, but some community level data, and is it possible to overlay that? And just thinking out loud here about, there's the question of whether OHA can do that and what their, you know, what they might be able to integrate into that, and or once you get the data, is there a way to do that? If it's not patient level, I don't.
Well, it would be patient. It would be patient level to the extent that they have the address, you know, for the patients, you know, assuming that they have the, you know, our attributed members, and they can, based upon their address, they can know which census tract, and then they know, you know, from the community data, you know, which census tracts fall into that more distressed area. It's not as finely tuned as if we were, you know, asking each patient, you know, and trying to score them, you know, into like the Prepare tool, but it may be a good proxy.
Yeah, thank you, Gal.
Sort of like the UDS mapper concept or something.
Yeah.
And then I'm pretty sure HealthShare has done something to integrate some sort of community data set. We don't have access to their bridge site, so I don't know what the latest is, but I know there's something they've integrated.
Okay, good. Other thoughts on this? We'll sort of chicken and an egg here, but we will get as well to some of those follow-up items the state sent us, which includes the demographic or the data, the additional data that they have that they might be able to sort of sort by, including PERT codes, eligibility codes, stuff like that. So I think when we get there, we may want to think about, are there any of those, can we use any of that to stratify in a way that might speak to risk as well?
Laura, this is William. I wonder if there's any way for us to identify the quality of the documentation and coding that is included in this, because I do think there's a gap that we as FQHCs have in the context of risk and calculating what that looks like. And I don't know how you get there. It seems like that's a kind of a challenge we just have, but if we can't really quantify it, we should at least identify for the state that we do think there's a gap there, and see if they've got some way to articulate that for us.
Yeah, I'm wondering if anyone else, I feel like some time ago, but I know Care Oregon had done some analysis around that. This is some years ago. If anyone has sort of recent analysis or information about that with the other CCOs, that could be helpful. Nothing off the top of our heads, but okay, good point, William. We're aware that comes up every time that we're all undercoding.
Individually, we haven't gotten it from any of the plans.
Oh, okay.
We've just done our own assessment.
Okay.
We've brought in a coding expert, and they've done a random sample to kind of see where our gaps are. But beyond that, we haven't had help. Does it demonstrate, I assume, undercoding or? Not super significant. There are some gaps with certain positions, but we didn't find anything that was like, wow, this is really affecting things. Okay.
And you're looking primarily at diagnosis code.
Okay.
And I'll say we're just the opposite. we're finding that our practitioners are undercoding because for so long.
Yeah.
On CPTs or on diagnosis?
Diagnosis. And it's like, slap a diagnosis on, it doesn't really matter. Yeah, they were in for a cold today and they have diabetes and hypertension, but I'm gonna put in the cold,
Yeah.
I'm not gonna put in all those diagnoses.
Right, because that's, yeah.
We're getting better, but, historically, when our CCO has compared our risk compared to our peers, we have always shown the lowest risk patients. And we just know that's not.
And you know that.
Yeah. There is a little bit of more patients are sicker, and so I'm sensitive to that.
Yeah. But definitely not less.
It's getting closer as we've been doing more work with our practitioners, particularly our newer practitioners are more savvy. Folks have been around for a long time, it's harder.
Yeah. I wonder if, this is not necessarily directly related to this project, but I know that the CCOs have every incentive for you to code accurately.
Oh, yes, absolutely do.
On that. So, if we might be able to think about whether there are some places that'd be willing to kind of do that audit to pay for a look into that so that we have some kind of validation or justification for that. I think it might be.
Well, and some of these will flow into this afternoon's conversation of the network development.
Sure, absolutely, right.
Would be value added.
Yeah, for sure.
I think one thing that helps us, but we are getting something from our Medicare plan that shows us, here's the risk score assigned to this person. Here's where we see you guys coding. And so we target those patients to get our coding up, get them in the clinic to make sure we have all their diagnoses documented. And I think that process has helped our physicians kind of make that part of their routine.
And how are the plans developing the risk scores?
Medicare actually assigns one.
Okay.
So
okay.
Yeah, so it makes it kind of easy. I don't know if the state of Oregon has individual risk scores assigned.
I was going to tell you the same thing, to take a look at that. But we get it on the Idaho side because we've got an ACO.
Yeah, I know about them in concept, but we are not getting that.
So it's almost
maybe
like
I
kind of
could talk to you later about that
thing that really helps identify those patients that are not, up to code.
Yeah. Thanks, Christy. Okay, I'm going to try to move this along.
Okay.
So, risk, obviously key. The state's going to have some baseline that I think we know is going to be inadequate. We want to think about and look at potentially the use of community level data, potentially something that might be an aside, but just sort of a defensive, position around our under coding and make sure we understand and know that. And then I want to come back to later when we look at some of the other demographic data the state has to think about whether there are other ways to segment to demonstrate risk. Price versus resource use, this is getting into, I think, utilization versus cost, I believe. I don't know if folks have thoughts on this. I'm not sure that the state's going to be able to do this kind of analysis, to be honest, unless we sort of approach them with the how-to and they have, with respect to utilization, we'll get to this later. I'm hoping that the state may be able to, in addition to these cost buckets, pull in some of those metrics that the CCOs are looking at around readmissions, things of that nature. And those are claims-based, and they obviously help produce those for the CCOs. So I'm hoping they might be able to get to some metrics like that to be included. Let me see what else I wanted to call your attention to. I don't know if folks had a chance to look at this. There's some nice, it just might be interesting to take a look at these reports. This was in the link to what we sent out, and they've got some nice you know, definitions, stuff like that, if people are interested. So I'm going to go through those, but if you want to go back to that report that was linked out, feel free to take a look at that. So they provide a fair, you know, a pretty high-level demographic, but then a lot of information by diagnosis, and that's certainly a question I have for OHA, which is to what degree will they be able to provide some analysis of either cost by diagnosis. This is just a prevalence number here, but you'll see later in the report they do look at cost bucketed by certain key diagnoses. So curious about people's reactions or thoughts to that, if that feels like something that would be of value.
I think it's definitely of value, but I wouldn't want to break it down just to one diagnosis, because if you have patients that have multiple issues going on, it's just because someone has asthma, but then they also have all these other issues. I think that's comparable.
Okay. So maybe even something that's one chronic condition, 2, 3 or more, something that might look that way.
Yeah.
Okay.
I think we have a lot of that information. The HR report, we had top health. But if we did go to something like this, it would serve as a bit of a chat point on the diagnosis and quality of information, cost information. If they totally botch, you know, if it doesn't jive with what we're looking at.
Yeah, and I just thinking ahead, you know, again about they're not integrating this with EHR data, so they're looking at just from claims of primary diagnosis. So they have to be able to see if at different times a patient was, what did I do? Different times a patient was, I guess, had a claim based on multiple diagnoses. So I'm not sure how accurate, you know what I mean, that's going to be. But good point, Dan.
Well, like asthma and a mental health.
Right, yeah.
They have both of those. They might be hitting the ER way more than someone that doesn't have a mental health.
Right.
So,
okay.
And Care Oregon did some of that work with their recent ED utilization pilots that was about, I think they closed out about 6 months ago. And of course, we saw on the grids that, you know, you can have your primary diagnosis, but add SPMI.
Right.
That's where you're going to have your cost.
Okay.
This list and the way it's displayed looks like it's like the traditional, like Medicare.
So the other thing I wanted to add, I think they need to break it down, not just by clinic, but clinic location, or at least by county, because those of us that have health centers all over the place, our Portland clinic is very different than the one we have in Astoria or in Silverton. Very different population.
Sure.
So to roll us up into one big number wouldn't make sense.
Fair point, and we'll ask about that. Part of my concern is I think they're often attributing to, I guess if you have different billing IDs for those sites, that might be feasible. I know most of you don't. When we do rates, I'm familiar with the fact that most of you don't.
But if they base it on where the patient is, then they could say, you know, Lynn County or Multnomah County.
And that's where the CCO part's really important.
Yeah. And I know for sure they have by CCO, but that might not even be nuanced enough, or might it?
It would be better.
It'd be better. Okay, so that might be a fallback if they can't get to county. Okay, I know I heard, let me pull up here, professional and all the breakdown around there, which again, I feel like this is a lot of, I'm not sure what, there's just a lot here, but I did hear from folks when we looked at OHA, the first version, a real desire to pull primary care out versus specialty. Let me ask, is there anything else that jumps out to you again around these professional fees and things that you feel like you'd really like to have pulled out? This, as you said, this is a Medicare.
I don't see specialty mental health.
Yeah.
Yeah, I think, again, being Medicare, when we get to OHA's groupers, they do have a lot of nuance around mental health. So I think we will be able to get into more that way. I don't know if it's in the professional. I'm sure there are some in the professional category.
Should be.
Yeah.
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 Psychiatric visit,
Yeah.
what does that mean?
Yeah.
Like in the top,
Yeah.
5 or no?
Right. There we
Oh,
go.
there it is.
Psychiatric
Yeah,
visit.
yeah.
But sometimes you don't know what that means.
You don't know what that is,
Yeah.
right?
Well, and yeah, I'm not sure we'll get a ton more nuance.
And if you look at other professional services on there, you know, it's the, second highest. So you throw in everything into other.
Right.
Second highest
Yeah.
cost.
Yeah.
Third highest cost.
I'm not
So.
sure we're gonna, I'm not sure we're gonna solve that here.
Yeah, no, but, you know, it's a question.
Yeah.
In terms of how they.
Okay.
You know, this sort of makes me think it used to be, in my experience, we really paid more attention to some of the Q Corp stuff
Yeah.
and the developments of all of
Yeah.
this. And honestly, over the last 3 years, I've not
Yeah,
paid any, so it's
Mhm.
sort of like, what is that?
Where'd that come from?
Who does, I guess?
Yeah, I don't have the answer to that.
and that goes a little to how's the state
Yes.
categorizing and evaluating this.
Yeah.
Right. So here then by outpatient facility, there might be a little bit more psych visits. Well, and again, this is not what we're talking about. This is that's facility. Yeah.
Okay.
I'm not sure we're going to have, you know, that ability anyway from the OHA data, but that's just another example. There was one other thing before we moved on to what the state provided that I wanted to ask about. I guess it was just back to those chronic conditions. Well, I'll call your attention to this, and we'll talk about this at the end. They do throw in as well some of those metrics, and as I said, the CCO utilization measures that I'm hoping OHA is going to be able to do. I mean, Health Analytics produces those reports across the board. I don't see why they wouldn't be able to do this. So, you know, I'm kind of assuming that you guys will have interest in potentially including those. How much do you think it's important to break down age and other demographics?
Extremely.
I
Yeah.
think it's very important. Okay.
And those are components of their existing rate bands.
Right.
So
They'll have it.
it's not new language.
No, yeah. Yeah.
And they are negotiating with the CCOs on rates, down to all of the different line item categories, inpatient, outpatient, so.
They have it.
They
Yeah.
should have
Yeah.
at least what they're using in their rate setting and negotiation.
Yeah. I agree. I'm quite sure they have it. And, you know, part of my question, which I'll pause after we look through this, that I'm trying to get to is just a sense of priority and how much do we want on this report, and, you know, what are kind of the most important factors to think about in terms of that segmentation and just volume of data that we want to seek from this. Like, are we feeling like, let's get the kitchen sink and comb through it and see what we can and kind of try to get, you know, get as much nuance as we can, or do we want to drive to a couple key things that we want to see in this report? Go from there. Kind of a big picture question.
Do they have any pharmacy data?
I don't think QCOR does, but the state will. There's a pharmacy category. this was the last thing I just wanted to say. As I mentioned, the diagnosis, and then they added sort of PMPM costs related to that. But to your point, doesn't capture comorbid. You know, they'd be overlapping some of those patients, right?
I don't see substance use disorders in there either.
I think that's also a different claim source, but the state does have some of that. I think we'll be looking at that. Thank you. All right, any other, again, I'm not necessarily looking explicitly for a reaction to this report, just to get your thoughts on like what looks of value, what's interesting, what might we want to kind of borrow from here. And I encourage you to look at it in more detail. Oh, here they do have some pharmacy. Any other observations on this, or should we move back to some of the data that the state's provided? Folks on the phone?
Overall, it looks really good. You know, I think again, you know, because the source is really claims data, that you don't, you know, we couldn't pull in EHR, you know, like Charleston Index that could give us a sense of what the comorbidities and the risk factors there are. But as it looks, you know, this is useful information, I think.
Okay, so something to consider as we move on. Let me close this out. And how did I, can you help me get back to the,
we like
that. Sure. Thank you. Okay, so let's talk about what the state provided to us, those groupers we discussed last time. Thank you. Yeah. That is that one. Perfect. Okay. So when we, I probably just need the, yeah. Thank you, Summer. When we looked at those big buckets that the state had, this is what defines those. And what they said to us last time is that they're willing to break out, you know, they can adjust essentially and provide more detail according to any of these buckets. They could combine, not more than this, this is the detail they can provide. Does that make sense? So if you want to see all of dental, we can, or as they showed on that report, there can be one line that's dental and it includes all of these things. So let me kind of walk through it and then get your thoughts on what is the value. So here's, as you see, dental, I think potentially could look at maybe dental preventative, think about a dental preventative versus other services if we wanted to somebody's point before, this is carved out of APM, but would you want to look at this? Inpatient, oops, that went quickly. Inpatient, so fast, is, so there's newborn, rehab, med surg, huge, you know, just huge categories. And to your point, Ron, on that other one, other is going to end up being like a huge thing. But what within inpatient might you want to look at here was the first part. So you can see there's mental health acute, acute detox. It's kind of random what is called out. It is so really maternity and newborn care. So, so anyway, I think, let me keep walking through, but you could at least get to some mental health nuance there if you wanted to, and if you wanted to break out maternity, could do that. Outpatient, family planning identified. Here's chemical dependency, part A and B, ER, mental health, other outpatient. Outpatient's a big, long category. emergency room in kind of one big category here, lab, radiology, professional fees, which is, you know, there's a separate professional category, but okay.
So, Laura, you know, I'm wondering, you know, when we're thinking about outpatient, you know, we want to be able to distinguish primary care from just any outpatient service. And I guess my concern with this is it may lump some things together. And if we want, so from a CCO perspective, you know, you really look at primary care as a distinct category, as opposed to all other outpatient services that may be hospital-based.
Correct. And Bill, I think one of the things we'll want to do is to really get some more clarity on what they mean by, hi, somebody's going to call, by outpatient. I believe that those outpatient categories, because professional is separated, those are probably hospital-related outpatient services, but we obviously need to confirm those. You'll see here in professional, this is where your PCP E&M is. This is how we're going to get, I believe, to your as close as we can to primary care. Here's one physician, other evaluation and management, here's primary care physician. So I think this is where we get to that largely, and it's not going to be perfect. These, you know, are we going to want to put school-based services in with primary care? I think, you know, those are largely you guys. I know there are some other non-health center school-based services, but would you want to throw those in or keep it as a separate line item?
So help me understand and think about what is it we're trying to do? Why we get all this stuff? What is it we're trying to either explore or demonstrate or have a better understanding of? Because that'll help.
Yep.
I'm not entirely sure what's the end game of getting the data.
So again, I think to our high-level goals, and then I welcome feedback from everyone about how you see this as of any added value. High-level goals to try to understand cost drivers. So thinking about what you want to look at in terms of combining or keeping as nuanced as possible where costs are and how they look for your patients relative to maybe an average or to one another. And then, so high-level cost drivers, and then ultimately sort of your long-term ability to impact, you know, those things that you think you may be trying to impact, I think would be the other question I would pose back to you. Are there things you're working on with your CCOs, you know, ED utilization that you have efforts at the clinic level to try to impact utilization of certain aspects of these services? We want to, I think, make sure that we're looking to isolate buckets that you could at least watch. Are we having some impact in that regard? Because there will be lots of things that regarding those inpatient and what have you that, you know, I think we would say to the state, like, we don't have impact around that, but look, our ED utilization is going down or below average, and we have specific interventions to do that.
So if that's the case, that turns people smarter than I. If these are the buckets in which the state captures the information and reports, wouldn't it make sense to say, give us all of them? Because then we have it at the granularity level of which the state has it. And if we then decide these are the 6 buckets that are the most important, we have that. What would worry me about starting to, absent data, what would worry me a little about choosing different buckets is as we get the data, then we start to say, oh, everything else is in this other bucket that we didn't ask for that level of granularity.
Right. We don't know.
And we don't know what's there. I mean, I appreciate the getting overwhelmed with data, because that's, in fairness, where we are with the Trillium data. We're trying to figure out, you know, we're getting it literally by the member level and trying to figure out what do we look at. But since we have it, and we have it in a database, we can now start to manipulate it, and we're not dependent upon going back to the payer to say, oh, can you give it? And in fairness, we kind of are, because there's information, for instance, about pharmacy that it just is generic, and we want to know, okay, give us more information about drug class. So I would throw that out as a.
I think it's a great point.
As long as we have the ability to collect it, digest it, and look at it.
I think it's a great point.
I don't know, those of you who are in the data world better than I.
And you raised the only thing that comes to my mind that is the potential counter argument is that
you get overwhelmed.
In the data.
Right.
So we'd love to open it up to other people.
You can't unbucket it, though, once it's been bucketed for you, and you don't have control as much over what goes into those buckets either.
Yep.
And other things could creep in over time that you don't want to have in there.
So that could bring us to closure pretty quickly on these groupers. If there's generally a prevailing opinion, like, let's just ask for all this, I think they could. I think what would be hard is to say, no, we want these 6 things, and then we want big categories, and we're not going to be able to keep going back and saying, oh, now we want to change this, and can you pull this one out? Yeah, exactly. So,
or they already think of some of these things in buckets, like everything's being captured, but they already have them bucketed in certain ways, just better understanding that.
Right. Well, like I said, these do relate to those original big buckets that they showed by the high level. Yeah, I don't know that they're looking at it in more nuance. I don't think they're looking at it that closely yet, to be honest.
Probably don't even know what half of it.
Well, and you know, I mean, part of it is going to be a function of kind of local coding, I would think. But that, I'm thinking if we have the more granular level, some of that might start to come out, because if we have lots of utilization in a certain bucket in my geography, and we're looking at Tim's data, and Tim has got nothing, and he's got a whole bunch of stuff somewhere else, that's probably not a function, you know, it might be a function of utilization, but it's probably more a function of coding, and we can start to say, well, you know,
You get to know that.
yeah.
You guys are good.
Yeah, we probably are, because I already identified. Or, you know, a hospital is coding things in a certain way. I mean, not to go too far, I mean, I know one of our hospitals brought in some coding consultants to help them with the emergency department, and I use help as a very descriptive term. And I will tell you, in the space of 2 weeks, their coding changed significantly. Their complexity, the patients, all of us have changed. They would say that they were more accurately reflecting the complexity of their patients, which they might have been. But I will say that their coding changed overnight. And, you know, there might be some things that we would catch like that, and otherwise we would have missed.
Has anyone ever seen any reports that show cost, specialty cost by disease category? Because I'm thinking, if you're actually going to look at how to manage someone, you're not managing by, well, I spent this much at the hospital. You're looking at what happened to this person, and how does, if someone has asthma, how does that compare to everybody else? So it almost seems like if you had disease categories and then the buckets of cost.
Yeah, we're starting.
That's actually more comparable.
Yeah, we're starting to look at that. To Gil's point, we're overlaying different databases, and so just yesterday we were looking at the the diagnosis of asthma against FPL, and it is over the moon high with FPL under 100%. So, you know, that's sort of, we're thinking there's a driver there. We're not sure how, but.
I was thinking almost more in terms of how different providers or communities may deal with
right.
how to treat.
Yeah,
somebody.
right.
And those
costs.
yeah,
Yeah.
looking at diabetes sort of in that way,
Right.
like how much is
Like,
Oh, yeah.
back
How are they
injuries,
treating?
knee
Yeah.
injuries.
Yeah.
There might be some communities where they're like, nope, surgery straight away. They never do PT.
Right,
And
right.
so their costs are really high compared to.
Yeah.
So I'm just wondering if that's something
That's a
that
good
we
point.
should try to push to see the data that way instead of the traditional cost buckets without any diagnosis context.
So I assume they would be able to do some of that. Again, they're reflecting, you know, based on, you know, it's as accurate as the claims are with respect to stating primary diagnosis, that they could do that. I can imagine that might be an area where it might be helpful to identify we want it for diabetes and asthma and, you know, these 10 or 5 things, but that's something to think about and ask for.
Yeah.
Okay. I just kind of was walking through these. As you see, a lot of detail in the professional. And I wonder if there are folks on the phone. Oh, there's a chat. Let me see. So exciting. Okay. Will we be able to see the data at the provider and clinic location level? This might have been from a while ago. Great question, Jill. I think Christy had asked that as well. And so because most of you don't bill by site, I think we're a little concerned about that, but I think we will explore how we can get more nuanced. Can they do something with respect to either patient location or county, or at, you know, at the very least by CCO, and then that you may be able, well, that may not help you, but for some clinic systems that span CCO boundaries, that may be helpful. And then we will not see provider level data. Is that the only one there? Okay. All right. So again, I wonder from folks on the phone, we haven't heard from you, if there's any more sort of reaction or comments, particularly to Ron's suggestion that maybe we just want to get all of this level of detail, and then we can figure out how we might want to roll up different categories to say what looks to be mental health costs, outpatient mental health, and what have you. How do folks react to that?
I think that makes a lot of sense, particularly as we're still trying to formulate the questions and that how we want to use the data. So rather have a broad base of the data to work from, and as we fine tune our questions, then we'll be able to maybe simplify things moving forward. But at this stage, I think starting broad makes a lot of sense.
I agree with that comment. More is better to start.
Okay. Anyone else on the phone? And remember, you may be on mute. Wanted to get back to and just let you know, I'm sort of surprised. Pharmacy, not a ton of detail there. That's all there is in pharmacy. Yeah. Just FYI.
Yeah. Surprising.
Okay. I'm not hearing any other comments. Sounds like leaning towards more of that. Christy, I may suggest when you say, and possibly looking at like cost by disease state, that may not be all the that we may want to look at bucketing a little bit there, inpatient, outpatient, other things. Okay, but let's consider that. All right, let me see what else we had from OHA to share. That's what, oh no. So here were some of the other variables when they talked about essentially what they would consider their demographics. So this gets to age. Obviously, we're not going to sort, oh, they have clinic name, but this is going to be your organization.
What is PERC? What's the second?
PERC are the eligibility codes, and I have a list of those because I do think that's something worth looking at. Is that a way we want to segment? But otherwise, it's kind of, I didn't think about, but is there anything we might want to look at in terms of somebody who's been on Medicaid longer or less, anything by that enrollment?
Yeah, I think so. Right.
Yeah. That doesn't necessarily mean enrollment with you. That's a Medicaid date. So I don't know if there's anything of value there. And then here's the additional claims. Wondering if we may want to pull out your open card and look maybe at all separately for those folks.
Was gender?
I think that would be helpful to have the open card separate.
Okay.
I think so, wasn't it? No, it wasn't.
I don't see it, but they must have some other.
They must have.
That's what I said, the demographic group.
Yeah.
If this is it,
Yeah.
I would be concerned.
Yeah.
Yeah.
They have a lot more information.
It doesn't have address, it doesn't have.
Right.
Many of those things.
Right.
Where's the homeless status?
That wouldn't be on there.
I don't think that would be on
They
there.
wouldn't have that. No, they wouldn't have that.
I
Okay.
feel like that top table is all this stuff in our, the what we get back report.
Right.
Uh-huh.
Looks like it just matches.
Yeah, I think
But is there more than that?
This is what they provided to me, so. No address. So that concerns me for that other conversation we had about, but that doesn't mean they don't have it. Maybe that's just what
they absolutely have.
they provided. They have it in some way. Is it integrated with their claims data is kind of my question. So let me, as I said, really almost the only thing besides age that I thought we might want to look at separately. This is what that PERC program eligibility resource code looks like. So here are some of those categories. So this will get to sort of age bands, adults, if people are qualifying with or without children, if they're qualifying through TANF. And I think there must be some down here related to disability.
Yeah.
That was the one thing I wondered if there would be blind and disabled with Medicare. Disabled adult children, SSI. So curious if there are thoughts, I'll try to pull these particular categories all up, about whether there's any value to looking at, I would think in particular, folks with disability status or
yeah. I mean, certainly that high level, the left-hand band.
Like here.
Yeah, I'm certainly not familiar with all of those levels.
Right. Any thoughts on the phone about that? What else is here? These are CHIP eligible.
Yeah.
So you could look at CHIP eligible, ACA,
yep.
and then disability. Foster care, I don't know if there's any. desire to look at some of those.
Sorry, do they include any race ethnicity data?
No.
No.
And I think they told us that last time.
They don't have that, you know? Why? Do they not collect that?
I think it's not, it may be in their eligibility for Medicaid and sort of a separate database. It's not integrated with their claims data is the point, which is what I think they provided to it.
Did they provide them?
That,
do they provide the member ID?
They
do,
member
right?
ID was on that last one,
So,
yeah.
conceivably, we could overlay it, but it would be easy.
Yeah, they did it.
And are we thinking about asking basically for a claims dump, or when we say reports, are we talking about a data file, or are we talking about a hard copy report with?
A hard copy report they're talking about. They're just kind of filtering through these as you go, you know, it's essentially all the OHP eligibility categories that goes on for forever. So rather than saying specifically which you want, which do you want, I guess give some thought to this and whether there's some value in looking at those. And I don't, so let me ask a question. Is there value in looking at some of those categories and how people qualify? And if so, is it something worth looking at relative to cost, or just to be able to say our profile of patients, you know, 50% of our patients are disability status, or, you know, it's sort of a check on patient complexity? Or would you want to know costs for this group, you know, align costs with those categories?
I mean, I don't know what it depends what else is between them.
Mm-hmm.
It's significant.
Boy, I might backtrack.
About all the data.
Yeah, I mean, if we're talking about getting this on paper reports,
yeah.
The complexity of trying to wade through all of this paper, you know, because if you take any one of these overlays and you say, okay, now I want to overlay it by agency, by I don't know how we could
do that.
I mean, I don't even know what the report would look like, much less how we would use it.
Yep.
Right? Because you start to think about some of the things you're asking for. I mean, you'd have a sheet of paper that would be
It'd either be like print like this, or
the New York City phone books.
Yeah. Agreed.
So is it totally out of the question for us to have any of this as a data file?
Yeah, I mean that's I think.
I mean, we'll ask about that.
Yeah, I mean I think that's what we really want, right?
I think so, because you know, particularly if we're gonna try to overlay, you know, EHR data, you know, to better understand what's going on with our specific patients. Or if we want to look at census tract information or things like that, it's that's going to be stuff we're going to need to manipulate the data ourselves for. So I agree. You know, getting a 40-page report isn't really going to be all that helpful. If we do, you know, it really and be very high level kind of snapshot. But to really help us manage and do something with the data, I think we're gonna, you know, it would be much better to have it in some sort of format that we can then integrate other data from our systems or things that we're getting from the CCOs with.
Yep.
Would that data, are they spreadsheets or?
I thought I understood that's what they might provide to us, but I don't know what form they're collecting this in. So fair enough. I mean, I think we need to follow up on that and whether we can get the data directly, whether it could be patient level data. That was not my understanding before. But we can confirm with some of that. And I think what I'm hearing, Ron, is if not, then maybe we want to come back and revisit the idea of that level of detail, and we would want to be doing some more roll-up.
Maybe we're better off, I mean, I kind of have low expectations from the state.
Yeah.
So,
Yeah.
just because they have data challenges.
Yeah.
Yes, they do.
Maybe we're better off, let's get some higher level reports from them, understand how they put it together, and we work with our CCOs.
Yeah.
Because I think we're going to end up spinning our wheels.
Yeah, I think you're right.
We've already started doing things with the CCOs. So if we can kind of align those things with how the state's rolling up the data, I think we'll probably get.
And we already know there's going to be a multiple month lag from the time that the CCOs get it, the state gets it, and they manipulate it.
Yep.
Under the open card.
So I've changed my mind. I'd like to retract my comment about this.
Okay. And you want none of it, or maybe a couple aspects of that? Too much info. Okay. We don't want a phone book. That's clear.
Yeah.
Sorry, somebody on the phone.
Yeah, this is William. I wonder if both make sense, where we get from the state some high-level reports, let them generate it. We can give them some of the criteria. But this is where I get lost in terms of the processes that we're going through. And so to me, this feels like a natural next step with the network development and data aggregation process, to where what we would want to do is say to the state, yes, give us that information, but if we don't have a place for it to reside, or we don't have a process for managing that, then it gets a little bit difficult. If it's just a pass-through to each health center with their own data, then I suppose that's one thing, but it misses the mark in terms of trying to get some benchmarking or get some, state level data. But even if it's, and I'm guessing this is going to be 6 months old, is how I'm looking at it, 3 to 6, not 1 to 3. And so the question is, we're really looking at this as a way of looking back and saying, here's what was reported, here's what we have, can we do some quality assurance on that data and make sure that what the state's reporting makes sense for where we are today, or use it as a way of assessing, what we thought we were doing versus what was actually being reported by the state. But this is where I get a little bit, I wonder how we're going to connect those together, because it seems like a natural linkage, but I don't hear us linking those together in terms of our processes.
Yeah, I think that's kind of to Christy's point that I would agree that the network is probably is the more realistic path to that more timely data to be used for that more nuanced sort of understanding and guiding quality improvement and things of that nature. And with that said, as you know, we've been pursuing sort of these multiple strategies for accessing cost data based on, what you all have asked us to do, because this whole process has been sort of 2 steps forward, 3 back, 1 forward. And some folks may not, William, obviously, even if a network moves forward, not everyone will participate. Not everyone in APCM may necessarily, it's hard to know. So I think we're sort of still walking down those parallel paths, but I think it's a really important question to think about for each of those uses, what are our goal and are they different? And for this, what is our goal with this data given the limitations that it has? Amy, yeah.
And these reports are only possible for APCM health centers right now because of patient attribution.
Right.
Right.
So that's why it hasn't been something broader than that.
Yeah.
But maybe it could be eventually.
Yeah, because the state doesn't know
Yes.
beyond those who participate in APM who you've distributed to. Okay, so we'll come back to that. Let me finish with some other metrics that I pulled out from, this is from your CCO report. So as I said, I have to assume that OHA, particularly their health analytics unit, should be able to provide some of these utilization metrics, which are part of your CCO report. Some of these are incentive metrics for them. And so the question is, would it be of value to have these well on a cost report, and essentially so that you would know for your own APCM population how you're doing relative to these measures? And I'll just leave them up there. This last line references some other, there are some additional kind of more nuanced admissions data. Yes, okay.
This is the one place where I like the other diagnoses related to admissions. I can appreciate that may capture some of our dual diagnoses.
Yeah, and there's, again, this is a CCO incentive metric here, ED utilization among those elements. So.
In the new metric set, there's the thing around the dental for kids and others and all.
Dental like ER or?
No, like kindergarten kind of readiness type measure of like having a well child and dental established.
Okay.
Yeah.
Allowed in. Okay.
Like that. I don't know.
Yeah. So I just pulled some of those that seem related to kind of total cost drivers, not the sort of quality metrics, but obviously I threw in the well child visits. If there are things like that that are claims, I guess it's potentially an opportunity to get those claim-based metrics, whether they're primary care metrics or reflecting, broader, kind of bigger cost categories. It's an opportunity to potentially get those. Yes, exactly. So, okay, we'll take a look at that whole thing, and it sounds like there's some utility to seeing if we can add some things like that. Anyone on the phone with comments about those?
These look good. I just try. Oh, go ahead, William.
Go ahead.
Go ahead, William.
Well, yeah, let me just say I think these make sense, but I would suggest that we focus on the 2020 metrics and the changes that are coming as well as really being a priority here is all I was going to say.
Agreed. I was pulling off of, this was the outcome report from 2019, so good point. Sorry, Gil.
Again, it's sort of slicing the information a different way because we will be getting this from the CCOs, but then, looking at the same kind of measures specifically with the lens of APCM. So I'm just trying to see, and it'll be interesting to compare. I mean, it seems like they should align pretty well, but
right.
Yeah. So
this would potentially include, I presume, your open card folks. And for those of you who have multiple CCOs, this would potentially roll those together, or we might be able to ask for them to separate that by CCO. I don't know. So yes, agreed. And Gil, again, back to that point about pursuing multiple paths. There are some clinics who still are not having success at getting any of this information from their CCOs, you know, even at a base level. So I think that's also part of why we're looking to work with the state, because there's some, we got all our Venn diagrams and some portion of folks for whom this might be their best source of data.
CCO 2.0 doesn't change that?
Well, I do think there's some things that imply there's some, I think, pretty big language around providing the tools necessary for providers to manage.
Yeah.
You know, I don't think it's as explicit as you must provide these reports, you know, is my sense. Just pulling up, you know, I think we've talked through most of these things, but if there are any other sort of thoughts or things to raise that you didn't see in some of the examples we talked about, that maybe thinking about reports you already do have access to that you find of value, and that we should sort of add to the mix. And my question here about volume versus value is just to that point. If we're, are we aiming for, and it sounds like if we have access to the raw data so that we can manipulate it, manipulate a data file, we would like as much data as possible. If not, if we're talking about static reports, we have some more work to do to refine and get to more clarity around that.
The after the last bullet for our presentation,
yeah.
We have age theory. I think Gail raised as well, but raised efficacy. So we'd love to still see that information.
Yeah.
Raising that, health, determinants of health equity. We can't do that work without that.
Absolutely.
So it is as relevant to any other information that we're talking about.
So, Tasha, I agree completely. And what I recall from our first conversation was that unfortunately, those demographics aren't integrated with these claims data. But if we are able to get patient-level data, then you could.
That's where we could conceptually integrate it.
I don't think they were committing to that, but where you could, but that you could then potentially integrate that at your end. OPCA can't do that because we don't have medical records. Right. Hi, Erin. That's okay. Okay.
Laura, so the only other thing, you know, I mean, just kind of going back to, you know, the Optimus report and how they use that counterfactual projection of the costs, you know, and if and we don't have what that methodology was, but, and I don't know if that's something that state could extend to this analysis, but that would be one way to continue to evaluate the success of APCM from a cost standpoint.
Good point, Gil. We'll raise that as well. Okay.
Well, I have a quick comment.
Yeah.
Is there any way for the state to provide those who are enrolled in APCM to the CCOs? Because if the people who are the members that are in APCM, if the plans, the CCOs have that data in their system, it'd be a lot easier for us than to get our reports from the CCOs to the APCM clients.
Oh, you think the CCOs would produce a report? Well, it would be a subset, right, for them. It should be if you're an APM clinic, shouldn't it be that all of your patients enrolled with a CCO are part of your APM?
No, because we have a lot that we haven't touched or reached out to.
Oh, you're assigned.
We're assigned, but they're not yet established in APCM.
Okay. And so
I don't know if that's a value.
Are you getting data for your total population now?
Yes, from some plans we are, but then we're having to try to match up people who are enrolled in APCM.
Yeah.
But if the state send that information to the CCOs and they had a way to capture it.
Oh, you
with
have,
their enrollment. I
you
don't know.
have more confidence in your CCO.
Or that you
I think that's asking.
cut back to them.
Yeah.
Yeah.
So,
I mean, you provide your list to the state, so you could do that theoretically too, and say, can I see a cost, can I see your report by this subset?
right.
Okay. So, turning to some next steps, and we might actually finish up here a couple minutes early. It's been a long log through a lot of data. We will touch base again. A couple of you said you may have some additional reports or things we could take a look at as templates, and so we'll follow up on those things. I'm wondering if there might be some people who might want to volunteer to kind of help be a sounding board for us as we pull together something that looks like a proposal back to OHA. Again, just a first start, because everyone will be involved in kind of what that proposal ultimately looks like. But I think it might be helpful if there are some folks who would be willing to take a look at kind of a first draft of recommendations and things. So that might be good. So once we do that, coming back to this full group to say, yeah, that looks pretty on target, let's go back to OHA to meet and talk with them. And again, might be ambitious, but we're hoping to get towards early 2020 for actually getting them to put this into motion. So.
I'll also add that with Laura's departure, I will be taking this on along with Krista Collins so that we both have the sort of APCM aspect and then the data expertise together. So you'll be hearing from the two of us instead of Laura from here on out. And we have taken good notes. We've recorded the call, and we're also going to transcribe the call. So we'll keep all of your comments in mind as we go forward.
I can follow up to ask again about volunteers unless somebody wants to speak up.
I'm always happy to look at.
Yeah, I'm
samples.
happy to look.
Thank you.
I think Vanetta would be interested.
Okay. Okay.
There you go.
Vanetta's being voluntold. Absolutely.
I think Vanetta would absolutely.
If you're gonna, all right.
She would be, but I'll let her.
Great. Okay. Any other questions about next steps, process, other final volunteers? And I'm realizing, okay. Okay, we'll be in touch about next steps. Thank you, everyone.
Thank you very much.
Thank you.
Thank you.
Thank you.
It's so nice to be here.
I know. I need to go, but I never.
I know.